Hi, my name is Krista Terrazas, and I will be presenting asthma. What is asthma? Asthma is when there is an airflow obstruction secondary to excessive narrowing of the airway. It is one of the most common chronic diseases globally. It can affect children greater than 3, adolescents, and adults, and it can usually be treated and controlled with medications and lifestyle modifications. Here is a picture where you can see risk factors for asthma exacerbations such as exercise, strong odors, stress and emotions, food additives, reflux, drugs, smoke, obesity, air pollution, allergens, viral and bacterial respiratory infections, or temperature changes. What triggers asthma? It can be exercise, pets, stress, pollution, odors, smoke, dust, cold air, fumes, and pollen. What is the pathophysiology of asthma? It is the inflammation in the respiratory mucosa, mainly found in the bronchi. Activated mucosal mast cells can be found in the airway surface. Mast cells initiate the acute bronchoconstriction response to allergens, exercise, hyperventilation, and fog. Cells then release and initiate the inflammatory response. They release macrophages, dendritic cells, eosinophils, neutrophils, T lymphocytes, structural cells, inflammatory mediators, cytokines, and chemokines. You will see thickened basement membrane secondary to subepithelial fibrosis. Increased airway mucosal blood flow equals increased airway narrowing. Increase in mucus secretion equals mucus plugs. And airway hyperresponsiveness is an excessive bronchoconstrictor response to multiple triggers, and it is a physiologic abnormality of asthma. How will you know if a patient has asthma or a friend is having an asthma attack? You'll see wheezing, labored breathing, coughing that's non-productive, difficulty getting air in. It will be worse at night or early in the mornings. You'll see an increased work of breathing and thick mucus occasionally. What tests can be done to confirm if you have asthma? The only test that confirms the diagnosis is a lung function test. You can also do aeroresponsive tests, and that measures methacholine or histamine, but is not very useful in practice. It usually helps differentiate between a chronic cough and asthma. Hematologic tests can be done just to specific allergens that may exacerbate asthma. Imaging studies can be done. You may see hyperinflated lungs, a pneumothorax, thickening of bronchial walls, but it does not specify whether or not these findings are of a patient that's asthmatic. Exhaled nitric oxide is a way to measure airway inflammation. It is usually used to check the compliance of medications of the patient. How do we treat asthma? We can use bronchodilators. They act on the smooth muscle in the airway to reverse the bronchoconstriction. There are B2 anergenic agonists, anticholinergics, or theophylline. Bronchodilators are not sufficient alone to treat patients with severe asthma or if symptoms persist. What are B2 agonists? They reverse and prevent contraction of airway in smooth muscle cells. They inhibit the release of mast cells. They reduce plasma exudation. They inhibit the activation of sensory nerve. They're given by inhalation usually, and they should be given with inhaled corticosteroids to treat underlying inflammation. They're at risk for asthma death if short-acting B2 agonists are used frequently as rescue medications, and that usually means there's poor asthma control. We have short-acting B2 agonists, such as albuterol and terbutaline. They have a rapid onset. They usually last 3 to 6 hours. They prevent exercise-induced asthma if taken prior to exercise. Increased use of short-acting B2 agonists can indicate poor control of asthma. High dosages given via nebulizer or meter dose inhalers with a spacer. Side effects include muscle tremors or palpitations in the elderly, fall in plasma potassium. Tolerance can develop but can be prevented with the use of administering inhaled corticosteroids. Long-acting B2 agonists such as salmeterol, formoterol, or indoxacarb are usually given once to twice daily. They last up to 12 hours. They can improve asthma control and reduce exacerbations when given with inhaled corticosteroids. Next, we have the anticholinergics, such as ipratropium bromide and dipropium bromide. They prevent cholinergic nerve-induced bronchoconstriction and mucus recreation. They are less effective than B2 agonists. They have a slower onset of a bronchodilator. They are used in addition to long-term beta agonists or inhaled corticosteroids when they are not controlled with those combinations alone. Side effects include dry mouth, urine retention, and glaucoma in the elderly. Theophylline inhibits the phosphodiesterase in airway smooth muscle, which increases cyclic adenosine monophosphate, which inhibits inflammatory cells. Oral or IV doses may be given. Oral is used in slow-release forms to maintain stable plasma concentrations. IV aminophylline is used to treat severe asthma or to treat severe exacerbations that are stubborn to short-acting B2 agonists. Side effects include nausea, vomiting, headaches, diuresis, palpitations, cardiac arrhythmias, epileptic seizures, and death. We should avoid these medications or conditions that block CYP450, such as erythromycin or allopurinol, and that reduce the clearance of medication and because they can raise plasma concentrations. This is no longer the choice of medication due to the list of side effects. Inhaled corticosteroids, I listed below the generic forms, but we most commonly know them in versions of Pulmicort or Flovent. They are the most effective first-line therapy. They reduce inflammatory cell numbers and their activation in the airways. Side effects include hoarseness, oral candidus, unless you can prevent it by using a spacer with your inhaler, suppression of plasma, and urinary cortisol concentrations. Systemic corticosteroids such as hydrocortisone, prednisone, methylprednisolone, they treat acute severe asthma or exacerbations. It's given IV. Side effects include obesity, bruising, osteoporosis, diabetes, hypertension, gastric ulcerations, depression, cataracts, and proximal myopathy. We should monitor bone density, give preventative bisphosphonates or estrogen. Here's a picture just showing how corticosteroids work on the airway, whether it be on the cells themselves or on the structural cells of the airway. Other therapies that may be useful for some patients can be breathing exercises, hypnosis, yoga, Splenotherapy, which is the breathing of mineral-infused air of a salt mine. And you can see below, people are laying in a mine, basically sleeping and breathing the salt, which may help them with their asthma. You can use anti-IG, immunotherapy, steroid sparing therapies. The most important thing is that every patient who has asthma knows the difference with medications that they are giving and when to appropriately administer them. You have medications that are for relievers. You have the others that are controllers, and the last are preventers. Then you have a combination of these therapies that best suit the patient. How do we administer or take our inhaler? Here is a meter dose inhaler. You want to take off the cap, shake it, breathe out, take a deep breath in. You're going to press down on the medication and hold your breath for about 10 seconds. The second picture is the same concept as the first, except it is showing you how to administer the medication with a spacer. Only difference being is that when the medication is administered, it will be trapped in the spacer, so you want to breathe slowly and deeply. Afterwards, you'll hold your breath for about 5 to 10 seconds and then breathe slowly and deeply once the medication is administered. Next, we can also manage asthma by a stepwise approach. Here is a photo example of how it works. You want to start the patient on a low inhaled corticosteroid as the controller, along with a short-acting B2 agonist. That would be step 1. If asthma symptoms persist, then we would move to step 2 using, again, a low dose inhaled corticosteroid, maybe adding another medication along again with your short-acting B2 agonist. We reevaluate the patient. If symptoms continue to occur, we can use your inhaled corticosteroid with a long-acting B2 agonist. You also have other medication choices and your short-acting B2 agonist as a reliever. And then you could go to step 4 if needed, and then step 5 until your asthma symptoms are managed. According to the Global Initiative for Asthma, there may be some ways to prevent asthma in children. Some examples would be avoiding environmental tobacco during pregnancy in the first year of life, ensuring a healthy diet for a mother during pregnancy and for infant afterwards, breastfeeding, avoiding acetaminophen or antibiotics during the first year of life for the infant, delay introducing solid foods, and maternal distress during pregnancy through early childhood could be related to asthma in children as well. That is the end of the presentation. Thank you for listening.